FC is a 47-year-old Caucasian female with colorectal cancer who presents to the clinic with altered mental status, diarrhea, nausea, vomiting, rigors, fever, and malaise, and new onset calf tenderness. FC was brought to the clinic by her daughter, who states that her mom started her new chemotherapy regimen of FOLFIRI with bevacizumab for her metastatic colorectal cancer, and she experienced nausea and vomiting that seemed to get better. However, 10 days after her first cycle, she developed severe abdominal pain, nausea, vomiting, and diarrhea. She also had increasing and worsening inflammation around her chemotherapy port. She had fever, shakes, chills, and worsening confusion. Her calf is also red and swollen and tender. She's also hypotensive, tachycardic, and has a fever of 38.8. She also says on a pain scale she is a 7 out of 10. Her past medical history: she had metastatic colorectal cancer, stage 4A. She has a history of chronic UTIs, obesity, prediabetes, and hypertension. Her family history: she has a breast cancer on her mom's side, colorectal cancer from her paternal grandfather, family history of diabetes and cardiovascular disease. Her social history: she's a previous 1 pack per day smoker who stopped in 1998. She drinks 3 or 4 drinks on the weekend. She's a widow who lives alone about 2.5 hours from the hospital. She has no known drug allergies, and her home medications include lisinopril 40 milligrams once a day, metformin 500 milligrams twice a day, ondansetron 8 milligrams every 8 hours as needed for nausea and vomiting, dexamethasone 8 milligrams on days 2 and 3 of her chemo cycle, and oxycodone 10 milligrams every 4 hours as needed for pain. And her last fill was for 180 tablets on 5/28/2019. Her inpatient medication list is meropenem 2 grams IV now, then 1 gram every 8 hours, vancomycin 2 grams IV stat, then 1.5 grams every 12 hours. She has normal saline to rehydrate her, 4 liters via IV with 1 liter to be given every hour until complete. She's on norepinephrine 0.05 to 3 micrograms per kilogram until she reaches a mean arterial pressure of 65. Metformin 500 milligram is being held due to her NPO status and mental status. Heparin 5,000 units subcutaneously twice daily has been ordered but not received. So FC's prioritized problem list: her high priority is going to be catheter site infection or bacteremia, calf pain due to DVT, chronic kidney disease, nausea, vomiting, and diarrhea, which will worsen the CKD, pain management because her pain is not being managed adequately. Medium priority is her dysglycemia. Low priority is the colorectal cancer, obesity, and hypertension because she is hypertensive. So our first problem is going to be the catheter site infection and septic shock. She has new onset bacteremia with an infected port, and this was evidenced by cultures taken from the port tip, exudate, and 2 out of 2 positive blood cultures. The culture was positive for gram-negative rods that were non-lactose fermenters. Her CBCs show elevated white blood cells and bands. There was no bacteria in her urine. Abdominal and pulmonary sites were ruled out, and the TEE ruled out endocarditis. She has pain, swelling, redness at the port site, along with fever of 38.8, chills, nausea, vomiting, and a confused mental state, all which indicate systemic bacteremia. Her assessment of drug therapy: she is on meropenem 2 grams IV stat, then 1 gram every 8 hours, vancomycin 2 grams stat, then 1.5 grams every 12 hours. Vancomycin is not appropriate for this patient. She has no indications for gram-positive coverage, and vancomycin does not have very good Pseudomonas coverage should her cultures come back positive for Pseudomonas. Furthermore, meropenem is appropriate, but the dose needs to be adjusted for her kidneys. The patient's past labs show previous infections with ESBL positive infections and show susceptibility to carbapenems and resistance to fourth generation cephalosporins such as cefepime. So cefepime is not an option for this patient. So our goals for this patient is to remove the port, treat bacteremia with an antibiotic that can treat Pseudomonas or any other multi-drug resistant bacteria, and start it as soon as possible. Avoid worsening her CKD and nausea, vomiting, and diarrhea due to antibiotic therapy. So our plan for treatment for FC for the Class B is to remove the catheter before she starts anticoagulation, start her on meropenem 2 grams stat, then 1 gram every 12 hours due to renal function. Her estimated creatinine clearance is 42 mL per ml, and in addition, add an aminoglycoside like tobramycin at 2 to 3 milligrams per kilogram every 36 to 48 hours, monitoring levels after 6 to 14 hours, and the tobramycin trough should be less than 1 microgram per ml. Treat her for 7 to 14 days. Now, rationale for this is the ISD guidelines say dual therapy can be used if there's a possibility of drug resistance in Pseudomonas, which she has indications for. We should also keep her gently hydrated with IV normal saline to maintain her kidney function. We will monitor for efficacy by monitoring till she's afebrile, monitor her white blood cells and bands via CBC, monitor antibiotic therapy when cultures, modify antibiotic therapy when cultures and sensitivities are available. Repeat cultures within 12 to 24 hours. For efficacy, for safety, we should monitor a kidney function for her creatinine clearance, monitor for neuro and autotoxicity associated with aminoglycosides and neurotoxicity with the meropenem, and neutropenia with the meropenem also. Patient education. Patient may experience nausea, vomiting, and headache. If rash and swelling occur, loss of feelings in extremities, or diarrhea occurs, notify the care team. Any hearing loss and decreases in urination should be reported to the care team immediately. For her DVT, assessment of disease, patient has a Caprini score of 7 and her D-dimer test was high at 4,000 micrograms per ml, which indicates an active presence of a clot. FC has a new onset calf tenderness, pain in the lower extremity, and ultrasound has shown her to have a deep venous thrombosis in the right tibial vein. Patient has risk factors for DVT. She is obese, she has a metastatic cancer, and is not ambulatory. So she's at risk for a DVT recurrence. So assessment of drug therapy. The heparin 5000 subcutaneously order was not given. Was ordered but not given. Dose recommended is for maintenance, not for initial treatment. Low molecular weight heparins are recommended for initial and long-term prophylaxis. And in patients with cancer, those are low molecular weight heparins are preferred per ASCO guidelines. Goal of therapy. So to treat FC, we're going to treat the DVT and also prevent another reoccurrence. Our plan for her is to discontinue the 5,000 units of heparin subcutaneously twice a day and start her on enoxaparin 180 milligrams subcutaneously once a day or every 24 hours. The dose is taking into account the patient's weight. This will continue while she's in the hospital and for 6 months after as prophylaxis. The rationale is once daily dosing has been shown to be safe and tolerated versus heparin in a study by Chong. Also, long-term use of low molecular weight heparins like enoxaparin have been shown to be safer than warfarin, as evidenced in a randomized controlled study by Meyer. We will monitor her for safety by monitoring her hemoglobin, her hematocrit, her fecal occult, monitor her for hyperkalemia, and check her baseline creatinine. We might want to also monitor her factor 10A activity due to her obesity. We will monitor for efficacy by using the factor 10A, also physical exam of the extremities for resolution of pain, redness, and swelling, and perform an ultrasound after 7 to 10 days if symptoms have not resolved due to rule out new thrombus formation. Patient education. So if the patient decides to stay on the enoxaparin, she will need to know how to use the enoxaparin, to inject it abdominally, and that it is subcutaneous. She will need to wipe the area with an alcohol wipe before injecting. There will be some bruising and some burning when she injects the enoxaparin. If she develops bloody stool or coughing up of blood, she will need to notify her healthcare team. Any warmth, swelling, or pain in the extremities that develops needs to be addressed immediately. For her chronic kidney disease, per KDIGO guidelines, chronic kidney disease is defined as a GFR less than 60 milliliters per minute, evidence of kidney damage such as albuminuria and electrolyte imbalances. FC has a GFR of 26.8 using the MDRD 4-scale variation. FC is classed as having stage 4 kidney disease. She has evidence of albuminuria. Her lab showed an increase of 2.7 from February 15th of 2019 to 3 on 6/19. Her phosphate is high, calcium is high, parathyroid hormone is elevated, and her vitamin D is low. Patient is showing signs of anemia due to her kidney disease. Her hemoglobin is 9.2. Assessment of therapy. Phosphate binder is needed, however, calcium acetate is not recommended due to worsening of hypercalcemia. Anemia needs to be addressed and treated, however, patient is not NPO, and so we suggest waiting till she's able to take medication orally before starting her on iron therapy. Patient is not a candidate for erythropoietin therapy because she has active cancer and has an active clot. Vitamin D stores are low and need supplementation. So our goal of therapy is to reduce phosphate levels, increase vitamin D levels, restore iron stores, and increase HGB levels, hemoglobin levels. So our plan for the hyperphosphatemia: place FC on sevelamer instead of calcium acetate to prevent worsening of hypercalcemia. Dose would be 800 milligrams 3 times a day to be taken with meals based on her serum phosphate level of 5.8 milligrams per deciliter. This would be started once FC started taking medication by mouth. The rationale is a systemic review and meta-analysis by Jamal et al. Non-calcium-based binders had decreased risk of all-cause mortality compared with calcium-based binders. Monitoring for safety: make sure the patient can swallow tablets, monitor levels and worsening of phosphate, calcium, and parathyroid hormone elevations. Efficacy: we will check serum phosphate and calcium levels every 3 to 6 months, periodic screening of magnesium, BUN, alkaline phosphatase, albumin, parathyroid hormone every 6 to 12 months. Patient education: she must swallow the tablet whole, no crushing, chewing. Take with meals. If GI pain occurs, notify care team, and expect some gas or diarrhea associated with the medication. If it worsens, reach out to your care team. Per KDIGO guidelines for the vitamin D supplementation is the same as if a patient did not have chronic kidney disease. Her vitamin D level is 10 nanograms per deciliter, and so her dose should be 50,000 units by mouth once a week for 8 weeks. Vitamin D levels may possibly help normalize her PTH levels. We are going to monitor her levels after 12 weeks and then adjust accordingly. If levels are maintained, the dose will be adjusted downward. However, if adequate vitamin D stores are not reached, we might consider calcitonin therapy instead. We will need to check levels of phosphorus and calcium after 1 month and then every 3 months. Effectiveness will be measured by changes in calcium, vitamin D, and phosphorus and PTH levels. Patient education. Patient may experience a bit of nausea. Take separately from other vitamins. Vitamin D is pretty well tolerated by most people. For the anemia, we will start FC on ferrous sulfate, 325 milligrams by mouth 3 times a day once she's able to eat. This will correct her low iron stores. Rationale for this is treatment of anemia will decrease mortality and cardiovascular incidence. There was an article about this in Lancet. Monitoring her HDB, her TSAT, ferritin levels, they should be checked after 3 months. Patient education. Patients should take iron with either vitamin C or orange juice to increase absorption. It may upset the stomach, so if needed, take with a small snack, but avoid antacids or any other medications that might interact with iron, so check with your pharmacist about the use of iron. Might experience a bit of constipation and nausea, so plenty of fluid should be taken. Assessment of pain. Pain is not being controlled. Patient could be converted to a fentanyl patch and used the 25 micrograms replaced every 3 days, and use oxycodone 5 milligrams twice a day for breakthrough bleeding. For dysglycemia, her blood glucose level is 215 milligrams per deciliter. Suggest using regular insulin via sliding scale per hospital protocol. Test blood sugar every 2 to 4 hours to monitor for hypoglycemia. Assessment of nausea and vomiting. It is controlled by ondansetron for the most part every 8 hours. However, consider using olanzapine 10 milligrams once a day. Patient does have a long QT interval, so we will have to monitor her EKG for QT interval for this patient. But olanzapine is an effective choice. Or compazine 10 milligrams every 6 hours if needed. Thank you.